I'll be talking about impact of ERAS in kidney cancer surgery. We know that ERAS is very well established for at least two major urological procedures, which is radical cystectomy and diversion and RPLND for testicular cancer. However, its role in other urological cancer surgeries like renal cell carcinoma is relatively less established. So we're going to focus on the impact of ERAS in kidney cancer surgery. I have no conflict of interest related to this presentation. We know that kidney cancer surgery is a complex surgical procedures which include partial nephrectomy for small localized kidney cancers, particularly for T1A disease and sometimes also T1B cancers, to radical nephrectomies, which is for larger kidney cancers, and then advanced kidney cancer surgeries, which is for patients who have locally advanced disease, and also for patients who've got IVC thrombus, which can be from level 1 to level 4. Majority of the upper tract surgeries, including kidney cancer surgeries, are now performed by minimally invasive surgery, which includes both laparoscopy as well as robot-assisted surgeries. Laparoscopy is perhaps still has a significant place in urology for kidney cancer surgeries. However, open radical nephrectomies and partial nephrectomies have a very clear definitive role. It is particularly for difficult partial nephrectomies, very large kidney cancers, and patients with IVC thrombus are preferably treated by open surgery rather than by minimally invasive surgical technique. An ERAS protocol is equally applicable to both. Generally, people think that it is only for patients who are undergoing minimally invasive surgery, but that's not true. Well, the initial workup is important, and it is important to identify the pre-existing conditions, determine the ASA status and the Charlson comorbidity index. It's important to optimize your patient for the selective surgical procedure before undergoing this major surgery. It's important that we line up the anesthesia evaluation. Nurses are a very important component of the implementation of the ERAS protocol. It's also important to involve GP, however it varies in various countries, how GPs interact with the main hospital performing these complex surgical procedures. Dietitian is again a very important component, and diet is important both for ERAS protocol and post-operative recovery. Physiotherapy, particularly the chest physiotherapy, and also mobilization of the patient is something that we need to be cognizant of and take necessary steps. All these things should be under rigorous quality checks to make positive changes so that the protocols can be changed according to the needs. So there's not one protocol which is equally effective throughout various healthcare systems. Preoperative counseling is also important in the ERAS protocol, in which you need to talk to your patients about cessation of smoking, for example, about the anticoagulation preoperatively. The preoperative nutritional status is important and overall healing of the wound. Avoidance of fasting, which is part of the protocol of the ERAS pathway, and we're going to talk a little bit more about this a little later. The carbohydrate loading up to 2 hours preoperatively, as we know, is an established component of ERAS protocol rather than the traditional way of prolonged fasting. The anesthesia should be standardized. The analgesia postoperatively and peroperatively should also be standardized. As early as possible, mobilization of the patient is the most important component, in my opinion, for patients' early recovery. So, in essence, ERAS is 3 major components. The preoperative component that we have talked about, then we have the intraoperative component and the postoperative component. So all these 3 different components are extremely important in achieving the goals of ERAS. So preoperative, as we've talked about, counseling, medical optimization, including diabetes if a patient has one, obviously irrespective of the complexity of procedure, mechanical bowel prep is no longer used. Exercise improves the tolerance of the patient, and ability to heal and get well soon after surgery is extremely important. And some of the centers very strongly recommend certain protocols in physiotherapy and exercise tolerance. As we've talked about, preoperative fasting is something which is now avoided, and carbohydrate loading, which is real opposite of the previous era of surgery, is the way. Epidural anesthesia is something that I personally like to avoid for patients who, for all urological cancer surgery, because in our practice, patients with epidural anesthesia takes at least 2 to 3 days to get out of the bed. And this is really counterproductive. And there are various other ways of controlling postoperative pain that we're going to touch upon a little later. Well, minimally invasive approach is preferable whenever it is possible, but in certain very complex partial nephrectomies, large, difficult radical nephrectomies, and patients with significant IVC thrombi are the one who probably would require preferably open surgical approach. The anesthetic protocols should be discussed. An institutional policy should be made about anesthesia protocol for patients undergoing intraoperative hypothermia should be avoided as much as possible. Postoperatively, the nasogastric tube, if placed, should be removed immediately after surgery before the patient is moved to the recovery room. The urinary catheters should also be removed as early as possible unless partial nephrectomy is done and the patient has calyceal repair, in which you would like to keep the intravesical pressure low. The prevention of postoperative ileus is extremely important, and it's one of the major factors responsible for delayed discharge from the hospital. The postoperative analgesia we're going to touch upon a little later. Early mobilization is the key, and early oral diet is again important in preventing ileus-like situation. And you need to continuously audit your practice so in order to improve upon the existing standards. So ERAS has rapidly developed in the recent years. General surgery were the first converts from traditional surgical approach to ERAS. Neurosurgery, colorectal, hepatobiliary, and now urology. In urology, radical cystectomy, radical prostatectomy, and RPLND are the major surgical procedures in which ERAS is an absolute necessity. And now we are seeing that increasing adaptation of ERAS in radical nephrectomy and partial nephrectomy patient. The whole idea is to reduce hospitalization time, reduce the medical expenses and complications after surgery. Now, if you look at the ERAS, we see This is nearly a total opposite of what we've been doing since we are operating and doing major surgical procedures with prolonged fasting, NPO 6 hours prior, which is still practiced for solids. But for clear liquids, it's important that they should be getting clear liquids up to 2 hours prior to surgery. Mechanical bowel preparation is definitely not required. Prolonged nasogastric tube is counterproductive and it causes paralytic ileus. The drains are either not placed at all, but if they are, they should be removed as early as possible. And post-operative bed rest, which was the standard of practice after major abdominal surgeries in the past, is now replaced by early mobilization. Now, a few words about prolonged fasting. The nil by mouth for prolonged periods preoperatively causes discomfort, anxiety, thirst, and nausea in patient. So it's important that we should not keep our patients NPO. In fact, sip till send approach is now more commonly practiced, which means that you take sips of fluid, a clear fluid, even until the time that you're called for surgery, or at least 2 hours before you put to sleep. The carbohydrate loading decreases the insulin resistance and thirst, maintains lean body weight and muscle strength. So it is important that the patient should be on carbohydrate loading rather than NPO. The prolonged fasting, the drinking of 8 to 10 ounces of clear carbohydrate beverages up to 2 hours before surgery is what is recommended now as a standard. The intraoperative management part of the ERAS protocol for nephrectomy include thromboembolic prophylaxis, which is again important. 5,000 units of heparin preoperatively. This is followed by low molecular weight heparin for prophylaxis. Now, personally, I don't use it for longer periods of time. I generally stop it as soon as the patient becomes mobilized. Next day after complete mobilization, stop the heparin or LMWH. But for patients who have undergone major IVC thrombectomy, up to 4 weeks of prophylaxis for chemical prophylaxis is indicated. Fluid management should be optimal. We know that patients who've got kidney cancer are very high risk of developing AKI and subsequent CKD as well. So the fluid management should be really optimal. One anesthetist should use pressors versus crystalloids because they can cause bowel edema and third spacing, which would make patient dry in the first 3 days, and then they would be in the diuretic phase, which is really not ideal situation. And hypothermia prevention, again, is something that we need to avoid. Now, mechanical bowel prep, as I have said earlier, is now outdated, and except for colorectal surgery and colonic surgeries, and where colon is being used by urologist for reconstruction, the mechanical bowel prep is no longer used. So what we do is enema is definitely required, and even antibiotic prophylaxis for bowel prep is also not used. And there is clear data indicating that patients who had mechanical and those who did not have mechanical bowel prep, there was no change in complication. Now, post-operative ileus is a factor which is responsible for delayed discharges from the hospital. The risk factor for post-operative ileus include male gender, advanced age, and major blood loss during surgery. The limited preoperative fasting with solids hold 6 hours prior to surgery, and the clear liquids 2 hours up to surgery is now recommended to avoid bowel-related complications. Most of our patients are advised to take this electrolyte solution, which is used by the athletes. Is really recommended up 2 hours before surgery. Virtually no postoperative fights fasting, therefore. Day 1, they start chewing gum. Day 2, black tea and maybe yogurt. And day 3, full liquid diet. And then you can progress accordingly. So all these factors are extremely important in preventing the postoperative ileus. One of the second most important reasons for developing postoperative ileus is the use of opioid. We know that the opioid agonists stimulate the 7-transmembrane G protein coupled with micro-opioid receptor on the postsynaptic neuron. And this initiates steps that reduce the release of neurotransmitters, for example, glutamate, acetylcholine, norepinephrine, serotonin, and substance P, etc., and promote the efflux of potassium, which leads to the hyperpolarization and hence reduced cellular excitability. So in the central nervous system, these actions are responsible for providing analgesia. Whereas these actions reduce the transmission and the blockage of the micro-opioid receptor in the GI tract causes changes in the gut motility and water secretion and absorption that may result in constipation and contribute to the development of postoperative ileus. So in the GI tract, these effects can be blocked by medications called elvimopam. It blocks the binding of the opioid agonist to the micro-opioid receptor and helps prevent constipation. Because the elvimopam does not cross the blood-brain barrier, it would not affect the analgesia effect of the opioid painkillers. The other important component of ileus prevention, besides the use of elvimopam with opioids, one of the problems with elvimopam is extremely expensive, and its availability is also an issue with most healthcare systems. It's not available in my country, and I've never used it personally. So there is another agent which is significantly cheaper, which is called naloxegel. Naloxegel is a much cheaper option, and it results in a saving of over $2,000 over a 6-day hospital stay compared to elvimopam. Now, radical cystectomy managed with the standard ERAS pathway, there were no difference in the post-operative recovery based on the use of elvimopam versus naloxegel. So these other agent can be neostigmine is another drug that I used quite frequently because of the non-availability of elvimopam. Chewing gum, as I've said, day 1 initiates the gastrocolic reflex and is extremely important in starting restarting the bowel activity, besides which standardized bowel regimen should be. One of the most dreaded complications, at least from patient's perspective, is pain. And pain control is something that is extremely important for a patient to be supportive and helping in the overall recovery. So for pain, obviously we have been using oral and injectable agents. However, the use of blocks like tab block is increasingly recognized as a way of avoiding complications related to the oral or injectable analgesics. We know that there are several nerves that supply somatic sensation to the abdominal wall, and they are not really involved in the visceral sensation. So tab block techniques are pretty standardized. These are the various landmarks for doing the tab block, either used on anatomical landmarks or ultrasound guided tab block can be given, and it can also be given perioperatively when you have already done the laparotomy. So besides tab block, use of oral paracetamol and gabapentin are helpful. However, the tab block doesn't work above the umbilicus, and for that, rectus sheath block is important, and rectus sheath block can take care of the somatic sensation or pain above the umbilicus, between the xiphisternum and the umbilicus. So rectus sheath block again causes significant pain reduction and helps in early recovery of the patient. Now, what agent should be used? There is data indicating that liposomal bupivacaine, which is not easily available and is also quite expensive, is extremely important if it is available, and because it provides pain control for up to 72 hours, and that's what the post-operative pain, the post-operative pain period is. It can be mixed with lidocaine, which provides early relief of pain, or with clairmarcaine with normal saline, and it is used. Now, before or after surgery is the question. If you use it before surgery, it would not let the pain cycle to initiate, and is considered and provides a stable hemodynamic status as well during the surgical. So in general, avoid narcotics, use topical and local infiltration, and the systemic treatment should be with acetaminophen and gabapentin. AKI is a common observation after kidney surgeries, be it partial or radical nephrectomy. So development of AKI is seen in about 15% of the patient. It is essentially related to the pre-existing body mass conditions like body mass index, history of hypertension, the complexity of the tumor, and if radical nephrectomy is performed compared to a partial nephrectomy. Now, development of clinically significant chronic kidney disease is seen in up to 56% of patients, and so development of AKI is one of the risk factors for developing of. It is seen more frequently in patients who have high complexity and intermediate complexity tumors rather than low complexity tumors. So kidney function preservation is one of the key factors to avoid long-term complications. The preoperative evaluation by a nephrologist is important in selected cases where you suspect that the patient is likely to undergo CKD or develop AKI. The preoperative fluids and electrolyte balance, optimize diabetes control, intra and post-operative blood pressures management are some of the factors by which development of AKI can be prevented. The predictors are baseline eGFR, warm ischemia time, and surgery type. So partial nephrectomy, less radical nephrectomy are more likely to cause these problems. Patients who undergo high level of IVC thrombectomy which is perhaps a very complex surgical procedure, are at high risk of developing various complications. However, because of the oncological benefit of this kind of surgical intervention, this is often performed, and they are often performed in a open surgical method rather than in a minimally invasive option. In our own experience, in this article published some years back, we look at the outcome variables to show the blood loss, the mean operating time, incision to wound closure time, total hospital stay, and development of various complications. So, in essence, the key component of ERAS is perform MIS whenever it's possible, follow the clinical pathway, and have a well-informed patient who can be partner in the recovery rather than just a spectator. It is multidisciplinary. Surgeons, residents, anesthetists, nurses, pharmacists, patient, they're all important component of ERAS implementation and recovery of patient. So about patient education, the EAU guidelines clearly states that counsel patients about cessation of smoking. Shared decision making is important to avoid unnecessary expectations after surgery. ERAS protocol should be implemented. Cigarette cessation, preoperative optimization, medical, physical, and mental is all important, and motivation of patient undergoing major surgical procedures. Now, hospital volume and component in decreasing the risk of complications after nephrectomy patients is indicated by this report, in which they've shown that the surgical volume of the hospital have a positive impact. We know that robotic surgery is becoming increasingly common, and after the successful implementation of radical prostatectomy and then radical cystectomy, radical nephrectomy and radical partial nephrectomies are also becoming standard operating protocols. Now, ERAS for kidney cancer, the objective is to facilitate accelerated recovery, optimize recovery, shorter hospital stay, fewer complications, and improve patient experience. You need to engage the team, and they should be positively contributing in the patient's recovery, and the patient himself, motivated enough by preoperative counsel, will be a much better patient than uninformed patient. Well, we know we live in a very disparate world. It is the healthcare system varies in various institutions and across the countries. It could be the resources is an issue. However, you need to have a clear goals, and the objective is to have as low complication rate as possible, quicker and earlier recovery of the patient, and a good experience patient after surgery. So to achieve these goals and to reach your destination, you can use a Safari or you can use an old car. The whole idea is to reach your goal and